My name is Gustavo Sosa. I'm the medical director of the NICU at Sutter Medical Center, Sacramento. And we are very fortunate to have today Dr. Satyan Laxminarasimha, who is chief of peds at UCD, well-known neonatologist, who among all his areas of interest, it includes persistent pulmonary hypertension of the newborn and congenital diaphragmatic hernia. And today he's going to give us a grand rounds on what is new in the management of congenital diaphragmatic hernia. Thanks for taking the time, Satyan, and take it away.
Thanks, Gustavo. Thank you for inviting me, and thank you for the kind introduction. Hopefully, if this format works for everyone, we will start having regular, maybe once every couple months, grand rounds, and even have outside speakers come in. So feel free to email me or Gustavo at the end of this session with topics and speakers that you have in mind, and we will try to organize more grand rounds of this sort pertaining to both neonatal and pediatric critical care topics. Okay, let me get started. I hope all of you can see my screen. The topic for today is an update on congenital diaphragmatic hernia, and we will talk about both antenatal, perinatal, and postnatal management. I will limit this talk to immediate postnatal management and not discuss ECMO or long-term management of pulmonary hypertension. Those are fairly complicated topics that require much longer time to address. So before I start, I want to remind you that there is a really nice guideline coming out of Canadian Congenital Diaphragmatic Hernia Collaborative. This publication came out in 2018 and is very helpful and the Canadians have also come out with an app that looks like this, the one that you see here with the black rectangle. And this includes lots of information about diaphragmatic hernia. And it's a free app. I strongly recommend that you download it if you're somebody who routinely manages diaphragmatic hernia. It's just called CDH, and it looks like this. It's from the Canadian group. So I will briefly review pulmonary management, some of the cardiac management, and how to mimic fetal physiology during CDH management. As a disclosure, I'm a principal investigator for the use of milrinone in diaphragmatic hernia study. It's a study done through the NICHD Neonatal Research Network, and I will briefly talk about that study as well. So diaphragmatic hernia is unique and is quite different from all other causes of PPHN. And its main three pathologies here are pulmonary hypoplasia, which is present not only on the ipsilateral side of the lung, usually the left side where the hernia is present, but there is significant hypoplasia of the contralateral lung as well. And this is important to remember as both these sites are hypoplastic here. The second pathology here is cardiac dysfunction, and we see it in the form of both right-sided ventricular dysfunction and also left-sided ventricular dysfunction. And the presence of left ventricular dysfunction in turn leads to pulmonary venous hypertension, which is much more difficult to manage in the setting of diaphragmatic hernia. And finally, the third component of diaphragmatic hernia is pulmonary hypertension, which is pulmonary arterial hypertension due to pulmonary hypoplasia and also presence of remodeled pulmonary vasculature. But the second component of pulmonary hypertension is the pulmonary venous hypertension. So both of these combine to cause pretty intractable and severe pulmonary hypertension in diaphragmatic hernia. Each of these three entities presents in different formats. So for example, pulmonary hypoplasia, as you can see in this X-ray, where you see a big bubble here with a small left lung up here, pulmonary hypoplasia predominantly presents with increased PaCO2. So that's the hallmark presentation of pulmonary hypoplasia. And extremely high PaCO2 can be a sign that this baby is not viable or salvageable. Pulmonary hypertension typically manifests due to extrapulmonary shunting of blood, right to left shunting of blood, resulting in hypoxia or low PaO2. and cardiac dysfunction presents with lactic acidosis and hypoperfusion and hypotension. So these three entities present in three different ways. The management of reduced PaO2 or hypoxemia is use of selective pulmonary vasodilators, oxygen, and if that doesn't work, typically VV ECMO. And the treatment of reduced cardiac function is use of drugs such as milrinone and epinephrine and sometimes hydrocortisone. And if these things don't work, use of VA ECMO. And finally, extremely high PaCO2 from pulmonary hyperplasia brings up an interesting question in many of these conditions as to whether we should offer ECMO to these patients at all, because there might be situations where when the pulmonary hyperplasia is extremely severe, we may not be able to manage this condition. But some centers have considered doing early repair and as a strategy to handle pulmonary hyperplasia or repair on ECMO. So these three entities present in with different clinical features, and their management is quite different as well. If you have any questions, feel free to put them in the chat box and I'll try to address them as I go along. So here is a very new study that came out in Annals of Surgery earlier this month from the CDH registry. So in this study, they took 7,000 patients with diaphragmatic hernia in the registry and observed that 27.7% of these patients required ECMO. When they excluded patients who really were not eligible for ECMO, those that were small in birth weight, less than 1.8 kilograms, premature, less than 32 weeks, or had major congenital or chromosomal anomalies, they landed up with around close to 6,000 babies with CDH, of which 29.1% were eligible for ECMO. So here, when you look at patients who did not undergo ECMO, their mortality was 12.6%, or approximately 1 in 8 children with diaphragmatic hernia who did not receive ECMO died or passed away. On the other hand, this is the interesting fact here. Of the babies that were eligible for ECMO and received ECMO, 46.9% of them died. So the mortality for patients who are referred for ECMO and receive ECMO in diaphragmatic hernia is almost 1 in 2. This is very similar to necrotizing enterocolitis, where if the baby undergoes surgery for necrotizing enterocolitis, the mortality is pretty high, almost 50%. Similarly, in diaphragmatic hernia, babies with diaphragmatic hernia that require ECMO, almost half of them don't make it. And that's something that's really important to remember. Second thing is that the PCO2, one single number, the lowest PCO2 during the first 24 hours of life, this is a really important factor because this number determines how hypoplastic the lungs are in a given patient. So here, if you see on the horizontal axis, different levels of PaCO2. Remember, this is the lowest PaCO2 in the first 24 hours of life, postnatal life. So if the PaCO2 is really, we can get the PaCO2 down to the 30s and 40s, there is really no benefit in offering ECMO to many of these patients. In fact, the survival among patients who did not require ECMO is much higher than those that required ECMO. But there is an interesting cutoff point, which is somewhere between 55 and 61 millimeters of mercury PCO2. This is the lowest PCO2. Once you get to this level, the benefit of ECMO starts increasing. And so it's pretty easy to determine in the first 24 hours of life as to what patients benefit from ECMO and how well they do after ECMO. Interestingly, even if you look at the ECMO line here, once the lowest PCO2 is close to 100, if you can get the baby's PCO2 below 100 in spite of real good ventilation, then the benefit from ECMO starts going down as well. And no matter what intervention you use, the survival becomes almost zero. So the lowest PaCO2 in the first 24 hours of life is a critical piece of information that will help you guide or counsel parents during the management of diaphragmatic hernia. So antenatally, there are several ways of assessing the severity of diaphragmatic hernia, and many of us are familiar with these entities. The first thing that we need to figure out is as to whether this diaphragmatic hernia is one-sided right-sided, left-sided, or bilateral. And that will really help us determine, because right-sided lesions have poorer prognosis and bilateral lesions have really poor prognosis compared to left-sided lesions. Associated anomalies, especially cardiac anomalies, are fairly common, and having a anomalous heart does increase mortality in these situations. The next set of measurements are really based on where the liver is. Is the liver up or down? Because if the liver is up, that has poor prognosis, and measurement of lung volume. Each of our centers has adopted different modalities of assessing lung volume. The most common thing that's usually used is what is called as the LHR ratio, or the lung to head circumference ratio. So what you do, there are three ways of assessing LHR, and I will show you one of the methods here. This is called as the longest diameter method. So what you do is you take a ultrasound image at the level of the four chambers of the heart, and then you measure the longest diameter of the contralateral lung, not the ipsilateral lung, the contralateral lung. And then you take a measure of the perpendicular area here. So if this is L millimeters, and if this is P millimeters, you multiply L by P, and you get the lung area of the contralateral lung. Then you measure the head circumference, and then come up with a ratio called as LHR here. And that's what is commonly used. And in every slide, I will put a small box with a green border at the bottom that tells you the level of evidence for each of these recommendations based on the Canadian paper. And as you can see here, LHR between 22 and 34 weeks of gestation is a very important entity, and 22 and 32 weeks of gestation. If it's a left-sided CDH, observed to expected LHR less than 25% carries really poor prognosis. If it's right-sided, even observed to expected ratio less than 45% carries a poor prognosis. Off late, we have been starting to measure lung volume using fetal MRI, and you can either measure total fetal lung volume and also assess liver herniation. And similar to LHR, observed to expected total fetal lung volume can be measured by MRI, and that gives us a prediction as to how we can manage these patients. So these are various ways of assessing severity of pulmonary hypoplasia and associated diseases prior to baby's birth. So there are three methods of assessing LHR, and these methods are called as the longest diameter method, the one I described to you earlier. There's a method called as the trace method. We literally trace the margins of the contralateral lung at the level of the four-chamber view of the heart. And then there's also a method called as AP diameter method, where you take the midclavicular line and then go anteroposteriorly in a perpendicular line. So most centers usually use the longest diameter, but more recent data has come out suggesting that the trace method, where you trace this area, might be much more predictive of survival without ECMO. And so some centers have switched over to using this method, but many centers more recently have switched to using MRI for this purpose. So moving along, one of the key factors that determine how well babies with PPHN do is the degree of ventricular dysfunction. This is both right ventricle and left ventricle, and so it's important to understand as to why we see more of ventricular dysfunction. Because of high pulmonary vascular resistance, there is always high right ventricular afterload in babies with diaphragmatic hernia. In addition, the herniated gut tends to impinge usually on the left side in left-sided diaphragmatic hernia, causing some problems that way. Then the liver is kind of positioned in an odd position, and in fact, many of you might have observed that it's a little tricky to place an umbilical venous line in a good position in babies with diaphragmatic hernia where there is liver herniation. So here, what you see is that there is some distortion of ductus venous flow, and because of distortion of ductus venous flow, there is not much of blood coming to the right atrium in the proper manner, and of the blood that's coming to the right atrium, only a small portion of it crosses the oval foramen and reaches the left side of the heart, whereas the majority of it actually goes down to the right ventricle. So in addition to this low flow crossing the oval foramen, there are other causes such as pulmonary hypoplasia, which reduce the pulmonary venous return. So a combination of reduced flow across the oval foramen and reduced pulmonary venous return contributes to low flow to the left ventricle And as you know, during cardiac development, low flow dictates low development, and this results in relative pulmonary hypoplasia of the left ventricle. So in addition, you have direct compression of the left ventricle by the herniated intestines, especially on the left-sided CDH. So a combination of all this with ventricular interdependence between the right side and left side results in right ventricular dysfunction and also left ventricular dysfunction. And you see biventricular dysfunction in babies with diaphragmatic hernia. So there is another issue with diaphragmatic hernia, which is the vicious cycle of pulmonary hypertension. So as I mentioned earlier, there is remodeled pulmonary vasculature, which in turn leads to pulmonary vasoconstriction and increased pulmonary vascular resistance. Because of this reason, you go on to have bowing of the interventricular septum, which further impacts on the LV preload. And in addition, you have reduced pulmonary venous return. This LV preload in turn leads to systemic hypoxemia, reduced coronary perfusion, and myocardial ischemia, which in turn leads to stretching of the cardiomyocytes, stretching of the RV, reducing RV contractility, which leads to reduced pulmonary blood flow, which further contributes to increased pulmonary vascular resistance. So this vicious cycle keeps happening in babies with diaphragmatic hernia, and this is something that needs to be interrupted for the baby to survive and do well. Diaphragmatic hernia, as many of you know, is a congenital condition that causes a lot of pathology, but there is a significant iatrogenic component to diaphragmatic hernia as well. For example, babies with diaphragmatic hernia, like any other fetus, have high fetal pulmonary vascular resistance. And once the baby is born, the fetal pulmonary vascular resistance falls. And this period is what is called as the honeymoon period when you manage babies with diaphragmatic hernia. It's usually fun to manage a baby with CDH on the first day of life because you get to do all the procedures like placing lines and tubes, and the baby tends to do relatively okay for the first few hours. But by the end of this period, the ductus arteriosus, which was serving as a pop-off valve, closes, and the left ventricular hypoplasia starts kicking in or becomes much more manifest physiologically, resulting in pulmonary venous hypertension. A combination of closed ductus and pulmonary venous hypertension results in a much more significant pathology, which is making pulmonary hypertension much more intractable. Subsequently, due to increased volute trauma and oxygen toxicity, you start seeing more and more pulmonary toxicity, which in turn leads to intractable pulmonary hypertension. So the ways to break this cycle are, one, to use gentle ventilation to avoid volute trauma, limit the use of oxygen to avoid oxygen toxicity, use milrinone early to prevent pulmonary venous hypertension, and finally use IV PGE1 to keep the ductus open so that the ductus does not close off and closing the pop-off valve. So a combination of these things usually helps in managing babies with diaphragmatic hernia and pulmonary hypertension. A second way of assessing severity of diaphragmatic hernia is by looking at the size of the defect. And this size of the defect is classified into A, B, C, and D based on how big the defect is. Unfortunately, there is no easy way of assessing the size of the defect before surgery, either antenatally or postnatally. And during the time of surgery, it's good to record the type of defect because that really also determines the prognosis. Babies who have size C and D defects tend to require a patch, as you can see here in this figure, and babies that require a patch tend to have poorer prognosis when you see them overall compared to other types because of the size of the hernia defect. So when do we deliver these babies? Initially, way back in late 90s, there was one report from the Neonatal Research Network that suggested that the outcomes might be better if babies were delivered around 37 weeks of gestation. And that tended not to be true in larger studies. And here is data accumulated from the whole of US that showed that babies with diaphragmatic hernia, just like babies without diaphragmatic hernia, tend to have the lowest neonatal mortality when they are delivered close to their due date. And so delivering these babies close to their due date probably makes more sense. So there is no advantage in delivering babies before 39 weeks of completed gestation. it's better to wait as close to the due date as possible before delivering them. So what do we do in the delivery room? This is the interesting part because this is where we get involved. It's good to have adequate information, especially if you have babies which have really, really small lungs. It's important to consider what ventilator strategy you want to take with you to the delivery room. So there are some centers that use jet ventilation, some centers that use a VDR, bronchotron, etc. So knowing exactly what the lung size is will help determine what kind of ventilatory support you might need. The second thing, it's worthwhile having a discussion with the OB as to whether delayed cord clamping is an option. There are several trials going on right now, one in France, one at CHOP, and one in Denver, which are looking at the feasibility of delayed cord clamping in babies with diaphragmatic hernia. And these trials are definitely reporting that this is feasible, but clinically no clear benefit has been shown yet in human infants. But either way, consider delayed cord clamping if the baby is reasonably stable. Because remember, this baby was in utero with a huge diaphragmatic hernia for as long as 9 months, and a few more minutes won't make a difference. So if you can get delayed cord clamping done, that would be of benefit to the baby, in my opinion. Subsequently, you avoid bag mask ventilation. I'm sure many of us have answered this question in our pediatric boards or neonatal boards. You definitely don't want to do bag mask ventilation in these babies. We tolerate typically SpO2 between 85 and 95%, which is fairly similar to what you would do based on NRP in different conditions. So that's what we would follow here as well. It's important to avoid PIP more than 25 centimeters of water and try low PEEP in these situations. That's because you really don't want to cause volute trauma or barotrauma to these lungs. Although we recommend 25 centimeters of water cutoff, there are instances fairly commonly where we land up requiring pressures as high as 30 initially for a couple of breaths, and then you might be able to back off. So this is something that you need to carefully assess and figure out as to how you should do in each baby. What is more recent is that if intubation only if needed, this is an interesting concept that has been brought out by the CDH Eurosimpo consortium, the European CDH guidelines, and we'll talk about that in a second. What they say is that if the baby has mild disease, we might get away without intubation. More recent data from Denver has shown that if you use the standard formula of 6 plus weight in kgs, as you would do for many of other babies, you land up increasing the chance of a right mainstem intubation in babies with diaphragmatic hernia. There is a concern that babies with diaphragmatic hernia tend to have shorter trachea, and for that reason, a shorter upper airway, and for that reason, the initial recommendation from Denver is to use a formula of 5.5 plus weight in kg, or rather use a half a centimeter less length while intubating with an endotracheal tube in these infants. Subsequently, you can get an X-ray and figure out where the tube is and adjust it accordingly. And other components are obviously orogastric tube suction. So of all the things that you do in the delivery room, this is probably the most important thing, because suctioning using a replogal tube, suctioning the stomach and getting the air out and reducing the inflation of the intestines is the key component that you need to do in the DR for these babies. The use of oxygen is a little controversial. Some centers use 21% O2, some centers always use 100% O2. There was a paper that came out of CHOP last year, in 2018 rather, where they looked at use of 50% O2, and in this particular paper, they increased FiO2 only if the baby was satting less than 80 at 5 minutes, and then they went up on the O2. And in fact, their protocol was as follows. Intubate and begin ventilation with 0.5 FiO2. If bradycardia less than 100 after 30 seconds of ventilation occurs, then you gradually increase FiO2 to 100%. If not, you continue with 50%. And if the preductal sats are 80% at 5 minutes of life, then you increase FiO2 gradually if needed. If that's not the case, then you can continue with an FiO2 of 0.5. And in fact, I believe that you can even titrate FiO2 down to maintain preductal sats between 85 and 95%. So one other thing that the European consortium recommends is use of lower PEEP. Instead of using a PEEP of 5, they recommend using PEEP of 2 or 3. And I will talk about the benefits of that in a subsequent slide. So the mortality, if the baby in the delivery room, you can get away using 50% O2 or less, the mortality in these babies is around 5.1%. On the other hand, if you can't maintain SATs with 50% O2 or less, and you land up increasing the FiO2 to 1, then the mortality in these babies is 30.9%. So there's a huge difference right in the DR as to based on the amount of O2 you need, because that indirectly dictates the severity of pulmonary hypertension and also the severity of lung hypoplasia. So routine intubation versus spontaneous breathing. So the European consortium, especially the unit in Rotterdam in Netherlands, has considered the use of spontaneous breathing or CPAP or high flow nasal cannula in babies with diaphragmatic hernia. This is totally against what we have been taught for many years while managing CDH. So what they did in this study was, if the baby was more than 35 weeks gestation with isolated left diaphragmatic hernia, with an observed to expected lung to head ratio of more than 50% and liver is in the abdomen, if these criteria are met, in 40% of the patients, they got away without intubation, where they could use CPAP in the delivery room or nasal cannula. But in the other 60%, they tried this, but then landed up intubating the baby. So theoretically, there is a possibility of managing these infants without intubation in some selected cases. The use of CPAP is a little more controversial. I have spoken to several people in this country through the network, through the CDH registry, etc. And they are usually uncomfortable using CPAP because the amount of air that you blow in is quite high and might cause problems. But use of either a low flow cannula or slightly high flow nasal cannula is something that can be considered as long as you're able to maintain SATs in these patients. Both these entities require very efficient orogastric suctioning, because if you can't suction, this will not work. What data do we have from animal studies for delayed cord clamping? Here is a study from Monash in Melbourne, Australia, where they have looked at a lamb model of diaphragmatic hernia. And what they have shown in this model is that if you do delayed cord clamping, fairly long, almost like 10 minutes, what you notice is that the pulmonary blood flow is considerably higher compared to early cord clamping. And this increase in pulmonary blood flow persists for a 2-hour period, and that's how long they followed these lambs. So there is some benefit to improved pulmonary blood flow, which indirectly means lower pulmonary vascular resistance in these lambs. The other thing they noticed was that the cerebral venous oxygen saturation measured through NIRS was much better in the physiologic delayed cord clamping group compared to the immediate cord clamping group. So there are benefits not only to the pulmonary hemodynamics, but also cerebral hemodynamics and gas exchange by delivering more oxygen to the brain. And that seems to be an advantage. But again, there are no human trials, and we still need to wait for more human trials to come through so that we can make a decision as to whether this should be routinely practiced in babies with pulmonary hypertension. So how do we go from the delivery room to the NICU? This is a crucial part of management of PPA, diaphragmatic hernia as well. So the key here is to avoid handbagging, because when you use handbagging, you really don't know how much pressure you are delivering, and it's quite likely that in the tension that accompanies the delivery of a CDH among providers, we'll end up bagging the baby with extremely high pressures, damaging the lungs. So it's really important that we use a T-piece resuscitator with appropriate PIP limits. Usually it's better to stay within 25 or 28 in that range and not go above it during initial ventilation, because once you damage the lung, you start adding a component of iatrogenic lung disease over and above pulmonary hypoplasia, and that can be pretty deleterious. So there are some centers, Utah, for example, uses high-frequency jet ventilation in the delivery room. And there are a few centers that take a bronchot, that transport bronchot to the delivery room to minimize volute trauma. So these are strategies that you might consider, especially if the observed to expected LHR ratio is low and you're worried about significant hypoplasia. These are entities that you may consider, but there is not much data on any of these entities. Overall key is to avoid volute trauma, and that's what we should aim on. So once you come to the NICU, what do you do with these babies? I still remember my early fellowship days when it was routine to manage diaphragmatic hernia babies with extremely alkalotic gas with a pH of 775, low CO2, high PO2, and we would beat the lung till we could get every molecule of carbon dioxide out and imbibe every molecule of oxygen we could. We also used a lot of sodium bicarbonate during those days, and those days are gone, and none of these things are considered to be valid right now. This mainly comes from a landmark paper that came out in 2002 based on experience from Colombia, where Dr. Jen Wang pioneered the method of gentle ventilation in diaphragmatic hernia, where he showed much better survival in these babies. And this was where the gentle ventilation concept with tolerable hypoxemia and permissive hypercapnia to minimize cardiac stress came through. In fact, for those of you who know Dr. Jen Wang or have attended his CPAP conference, he officially retired last night, and there was a really nice ceremony honoring him, which was very wonderful to attend by Zoom, of course, where there were many pictures of which one of this was him arranging CPAP using his Hudson prongs in a baby. This was what I call as the tale of two cities, where Dr. Mary Ellen Avery herself evaluated BPD rates in 8 different NICUs. And then she showed that the incidence in Center 3 here is Colombia, where the survival from among premature infants was as good as any other center, but the incidence of BPD was way, way lower. And this was a New York Times article in January 1987 highlighting his achievement. So this is Dr. Wang at his retirement yesterday. It was really nice to watch him. He also subsequently came up with a paper of their experience with 120 infants with diaphragmatic hernia with permissive hypercapnia and spontaneous respiration. So instead of maintaining the PaO2 really high in the 200 range and PaCO2 in the teens, we started doing permissive hypercapnia with tolerable hypoxemia, and that's called gentle ventilation, and that ventilation is very effective in avoiding cardiac stress. The second thing to remember with oxygenation is that we really worry about, just like the fetus, we really focus on optimally oxygenizing the brain and the heart. Those are the two main organs. And for that reason, focusing on preductal PO2 is really important. And in this case, saturating between 85 and 95 preductally is really crucial. You don't really care too much about postductal as long as the postductal sats are above 70%. But as long as the pH is maintained above 725, lactate levels are normal, for the most part less than 3 to 5 millimoles per liter, and the urine output is adequate. If you're not able to maintain adequate pH and avoid lactic acidosis, you need to focus on higher O2 levels. So where does this data come from? There is really no human data evaluating optimal oxygen saturations in term babies with PPHN. And most of the data comes from animal studies. This is the one done by Abe Rudolph at CBRI in San Francisco, where he showed that maintaining PaO2 levels below 45 or 50 millimeters of mercury can give rise to rapid, alarming increase in pulmonary vascular resistance. So he went on to show that hypoxia causes pulmonary vasoconstriction, normoxia causes pulmonary vasodilation, but hyperoxia, targeting PaO2 above 100, does not cause any additional vasodilation. So this is similar to the way where we cannot deal with excess food. Similarly, we can deal with excess oxygen as well. At the same token, not having enough food or hypoxia can be lethal as well. And that's important to remember. So saturating below 85 in a baby with diaphragmatic hernia can be really, really bad. And we should avoid saturations below 85 and also severe acidosis. Acidosis exacerbates hypoxic pulmonary vasoconstriction. So a combination of low pH and low SATs is much more detrimental to a patient than just having hypoxemia. So we should avoid the combination of severe acidosis and severe hypoxemia while managing babies with diaphragmatic hernia. So this brings us to an interesting question as to where we should measure PaO2. We know that the optimal preductal PaO2 is around 50 to 80 with SATs 85 to 95. But it's important to remember that the key area where pulmonary vascular resistance is measured is the precapillary pulmonary arteriole. And the PaO2 at this site is dictated by alveolar O2, which is P uppercase AO2. So 2/3 of PVR is determined by alveolar O2, and the other 1/3 is determined by pulmonary arterial PO2, which is the mixed venous PO2. So both these entities matter, And the reason why we use preductal PaO2 is because we cannot really measure alveolar PaO2 in any reasonable fashion. And for that reason, we use alveolar PaO2 as a surrogate for, preductal PaO2 as a surrogate for pulmonary venous PO2, which is thought to be very similar to alveolar PO2. And for this reason, it's really critical that we assess preductal oxygenation and not postductal oxygenation as we do with an umbilical arterial line. And there was a paper 3 or 4 years ago from Jason Geen and John Kinsella from Denver, where they showed that by using preductal measurements, they could avoid the use of ECMO and they could avoid many other unnecessary interventions if they solely focused on preductal PaO2 using right radial arterial lines. So if you don't want to put a right radial arterial line, rely more on pulse oximeter, preductal pulse oximeter in these patients. We also struggle with optimal definitions for hypoxemia and hyperoxemia. And this was an interesting paper that came out of CHLA and a few other centers, where they showed that there is considerable variability based on pulse ox and PaO2. For example, if you consider a PaO2 less than, see, for example, this line up here, what it shows is that if the baby is saturating 85 to 86%, the chance of having, the risk of having a PaO2 of less than 41 is pretty high. It's less than 50 is almost 80%. Similarly, on the higher end as well, there is considerable variability. And if the PaO2, if the SAT is 85 to 96%, there is approximately a 10%, 5 to 10% chance that the PaO2 in this baby might be above 80. So these numbers indicate that there is considerable variability in pulse oximetry, especially after transfusion in babies. And for this reason, periodic checking of blood gases is really crucial while managing babies with PPHN of any cause, especially diaphragmatic hernia. So this brings us to an interesting conundrum, because sometimes you'll end up seeing babies with diaphragmatic hernia who are saturating 85%, which is okay based on what the guidelines I showed you so far, but the baby is requiring inspired oxygen of around 30%. The question is, should you leave these patients alone like this, or should you consider increasing the O2 to around 50% so that the SATs can be improved to somewhere around the mid-90s? There are no studies addressing this question in human babies, but my preference would be to give a little more oxygen so that the saturations can at least be in the 90s if the PaO overall inspired oxygen concentration is less than 60%. Because if you go above 60%, you do cause negative effects of hyperoxia. So data for this comes from a study by Munmun Rawat and colleagues, where they looked at lamps with meconium aspiration and PPHN. And here the pulse oximetry was classified into low, 86 to 91%, moderate, 90 to 94%, moderately high, 93 to 97%, and very high, 96 to 100%, mostly 100%. And what you can see here is that when the pulse ox is below 90%, this is not good. The pulmonary vascular resistance is very, very high. On the other hand, when the pulse ox is around 90 to 94%, if the pulse ox is extremely high, near 100%, then again you start seeing an increase in pulmonary vascular resistance, as seen by this orange line. And now the trick is between choosing SATs of 90 to 94 versus 93 to 97. Interestingly, what you see here is that going from 90 to 94 target to 93 to 97 target really does not markedly increase PaO2 in the arteries, but does involve an increase in FiO2 or the alveolar O2. And for that reason, you do see a significant drop in pulmonary vascular resistance. So using slightly higher O2 to achieve slightly better SATs might also be important in managing babies with severe PPHN. So if you have a baby who requires around 30 to 40% O2 or anywhere up to 50% O2, it might be prudent to maintain their SATs in the low to mid 90s rather than have them saturate in the 80s. Okay, so what about CO2 levels? With CO2, it's very evident that mild hypercapnia and having adequate hemoglobin are really important for cerebral blood flow. As you can see here, maintaining PaCO2 between 50 and 60 in animal studies results in much better blood flow to the brain. And having anemia also reduces the amount of oxygen delivered to the brain. So maintaining reasonable hemoglobin, preferably at least 11 to 13 grams per deciliter or higher, is really crucial while managing these patients. Interestingly, severe anemia in this particular model can also reduce pulmonary blood flow. So avoiding anemia and avoiding extreme hypocapnia is important while managing patients with PPHN because you don't want to deprive the brain of its oxygen supply. So what type of ventilator do we use initially while managing babies with diaphragmatic hernia? The answer to this question was given to us through a very important trial called as the Vichy trial, which came from the CDH Euro Consortium, where the randomized babies, this is one of the, probably the only trial in CDH where the randomized babies to two different types of ventilation modalities. The randomized babies to high frequency oscillatory ventilation, where they used a mean airway pressure of 13 to 17, frequency of 10 hertz, amp of 30 to 50 with an IE ratio of 1 to 1. So these were the settings that were used initially on the high frequency ventilator. On the conventional ventilator, on the other hand, they used a PIP of 20 to 25, a low PEEP of 2 to 5 with a reasonably high rate of 40 to 60. So there was a huge difference in how these settings were arranged. The conventional ventilator settings were of low mean airway pressure with low PEEP, whereas the settings on the oscillator were probably moderate to high mean airway pressure for a baby with diaphragmatic hernia. In this trial, they randomized 171 infants, and this was probably one of the biggest randomized controlled trials in diaphragmatic hernia to date. And what they observed was that the primary outcome of severity of chronic lung disease or death was not different between the two groups. The p-value was 0.13. But there were several subtle benefits from using conventional ventilator at a low setting. The length of ventilation was lower, the need for ECMO was lower, the duration of inhaled nitric oxide, the need for inhaled nitric oxide was lower, the use of sildenafil, and the duration of use of inotropes were all lower in the arm that was initially randomized to conventional mechanical ventilation. So this clearly shows that using conventional ventilation is probably beneficial, but the thing here is that the oscillator used high settings, which we really do not recommend. We do not, and in this study, what they suggested, what I take away from this study is that initially start off with a conventional ventilator with low settings, and if that's, and increase the settings, and if that doesn't work, if you can't maintain the PaCO2 less than 65 millimeters of mercury, despite a conventional ventilator rate of 60 per minute with a PIP of 28, then switch over to an oscillator. But we don't know if this difficulty or this negative effect they experience with the high frequency oscillator applies to other modes of high frequency ventilation, such as VDR or high frequency jet ventilation. We don't know the answer to that. And also, there is this gentle oscillation where you limit mean airway pressure on an oscillator to a maximum of 15 or 16 centimeters of water. Start off at 10 to 11 centimeters of water and then maintain low mean airway pressure. We don't know if such oscillation is more beneficial. We don't know the answer to those questions, and we still need more studies to address them. So why does using high mean airway pressure using an oscillator cause problems in diaphragmatic hernia? If you think of this to be alveoli in babies with diaphragmatic hernia, if in the absence of surfactant, in the absence of proper recruitment, you can have asymmetric lung disease. If you use high PEEP or high mean airway pressure in these situations, the alveoli can really expand and become fairly big. And when they increase in size over and above their normal size, remember these alveoli are supposed to be small and hyperplastic. If you try to inflate them to a bigger size, then these alveoli expand and compress on the blood vessels right next to them, the alveolar vessels, thereby causing increased pulmonary vascular resistance. On the other hand, the other small alveoli, you can probably dilate them better. So having more alveoli that are extremely hyperexpanded can result in compression of the blood vessels causing increased pulmonary vascular resistance. On the other hand, if you use low PEEP or low mean airway pressure, you might be able to distend the alveoli to a much lower degree, which is probably normal for those hyperplastic alveoli in diaphragmatic hernia. And in such an instance, by giving inhaled nitric oxide, you might be able to dilate these vessels better. So the effectiveness of inhaled nitric oxide might be much better when you use with low PEEP or low mean airway pressure compared to extremely high mean airway pressure, as was seen in the high frequency arm of the Vichy trial. So the second thing is, what's the benefit of using low PEEP? So if you assume this green line here to be that a pressure volume curve of a parenchymal lung disease patient, such as meconium aspiration or RDS, and this red line to be the pressure volume curve of a baby with diaphragmatic hernia, if you use a pressure of something like 25/5 with a delta P constant at 20 centimeters of water, you'll end up getting a nice slope with a PV curve, PV loop for babies with parenchymal lung disease. Using the same pressure in a baby with diaphragmatic hernia because of the lung hypoplasia and low volumes will result in much poorer compliance in these babies. Instead, if you use low PEEP of 2 and a PIP of 22, you might be able to get away with much better compliance because you're capturing the part of the pressure volume curve that has the highest slope, and this might be beneficial in some babies with diaphragmatic hernia. So use of low PEEP might be beneficial in the initial management of babies with diaphragmatic hernia using conventional ventilation. Are there any studies to show that? There's only one study, and unfortunately, this study was done only for a few hours in the post-op phase of diaphragmatic hernia, not pre-op phase. And in this study, they showed that using a PEEP of 2 centimeters paradoxically led to lower FiO2 and many other beneficial effects compared to the use of 5 centimeters of PEEP. But again, this study was done after surgery, not before surgery. So this shows that at least in post-op patients with diaphragmatic hernia, use of high mean pressure can cause air leaks, can cause many other problems such as increased pedeations, reduced postductal saturations, and impaired venous return. And in fact, developing an air leak and a huge pneumothorax is not uncommon in babies with diaphragmatic hernia with the use of high PEEP or high mean airway pressure. So what are the initial settings that we ideally like in these babies? Here is the high frequency oscillatory settings, and here are the conventional settings. Volume guarantee ventilation with a VT of 4 to 5 ml per kg is really preferred. Use of less than or equal to 25 centimeters of water PIP, around 3 to 5 centimeters, preferably 3 centimeters for PEEP. And the rest of the settings are over here on this slide. With high frequency oscillator, try to start off with a mean airway pressure of 10 to 12 centimeters. Rarely go above 16 centimeters when diaphragmatic hernia, and the rest of settings are shown here. So avoiding high ventilatory pressures and volumes is really important, but there is one problem with this. If you use an extremely low tidal volume, like 3 ml per kg or something like that, the issue with these babies with diaphragmatic hernia is that their trachea are very compliant. And so the dead space in these babies is pretty high, and anytime you use PIP, a good amount of tidal volume is lost just within the trachea because the trachea tends to balloon with each inspiration. And this is important to remember, and for this reason, most of us use somewhere between 4 to 5 ml per kg and really don't drop the tidal volume too much just because the lung is small, because the dead space might be higher. There's a study happening in London right now where they're comparing 4 ml, 5 ml, and 6 ml per kg in random sequence in diaphragmatic hernia, and hopefully that study will give us more information as to where we should proceed. Moving briefly to inhaled nitric oxide, almost 2/3 of babies in the US land up getting inhaled nitric oxide, although on paper, the AAP does not recommend the use of inhaled nitric oxide in diaphragmatic hernia because of one trial, which was the NENOS CDH trial, where they showed that use of inhaled nitric oxide actually resulted in higher need for ECMO, 80% versus 53.6%. But the thing to realize here is that these babies were very sick with oxygenation indices in the 46 to 45 range. So these babies were almost at ECMO level even before receiving inhaled nitric oxide. And for that reason, we believe that inhaled nitric oxide was not very effective. There is a new trial that's recruiting patients in Europe. It's called as the CODINOS trial, and actually I'm talking to those PIs tomorrow to get more information as to how their study is going, and if I hear any new information, I will email it to you guys. So why does NO not work well? Part of the problem in diaphragmatic hernia, as I mentioned earlier, is presence of left ventricular dysfunction. If the LV ejection fraction is less than 55, the need for ECMO in these babies is much higher, 42%, as opposed to when the ejection fraction is more than or equal to 55, where the need for ECMO is only 15.6%. Similarly, non-responders to inhaled nitric oxide have a much higher incidence of LV dysfunction compared to responders to inhaled nitric oxide. And we do see a combination of LV dysfunction along with poor response to inhaled nitric oxide will lead to increased use of ECMO in these babies. The reason why LV dysfunction is important because in these babies, remember I told you the mortality is so high in these babies. In presence of LV dysfunction and RV dysfunction, these two are much more common in babies that land up on ECMO compared to babies that do not need ECMO. So ventricular dysfunction is something that you have to keep a very close eye on during echocardiograms while managing babies with diaphragmatic hernia. So the reason why left ventricular dysfunction is so important is because if you have LV dysfunction, you'll end up having elevated LA pressures, and elevated LA pressures in turn cause pulmonary venous hypertension. And when there is pulmonary venous hypertension, use of inhaled nitric oxide actually causes more lung edema. This is similar to having a party where there is a clog, and this clog is left ventricular dysfunction. And if you keep on flushing similar to using inhaled nitric oxide, the blood won't flow back to the left ventricle, and instead you can land up with MS, which is pulmonary edema. So a more efficient way of managing these patients is by using milrinone first, which is like using a plunger to get rid of the obstruction. And once the obstruction is relieved, then you will be able to relieve pulmonary edema and then use inhaled nitric oxide much more efficiently. So use milrinone first, improve ventricular function, and then consider using inhaled nitric oxide. So I mentioned briefly that we are running a trial of evaluating milrinone in diaphragmatic hernia through NICHD, and so far we have enrolled 31 patients out of 66 patients. And hopefully in a couple of years, I will have more results as to how to use milrinone in diaphragmatic hernia. So a combination of milrinone, PGE1, and nitric oxide works very well in diaphragmatic hernia. For example, if you have a baby with severe PPHN with RV dysfunction, the RV function is so poor that you start seeing huge dilation of the RV because the afterload is so high. If the ductus starts closing down here, the path that the RV had is starting to disappear, and for that reason, RV dysfunction gets worse and worse. The three-drug combination that works very well in this condition is IV milrinone to improve function of the right ventricle, inhaled nitric oxide to reduce pulmonary vascular resistance, and IV PGE1 to open up the ductus so that there is a pop-off where the RV can empty into the systemic circulation. And one benefit here is that by pumping blood into the systemic circulation, you actually maintain systemic hypoperfusion as well. So there are several benefits of using IV PGE1 in diaphragmatic hernia. And finally, management of blood pressure. Use of dopamine is usually not preferred if you can avoid it. A more selective agent such as norepinephrine or vasopressin is probably a better drug to use in this condition. And the guys in Denver have studied this much more in detail. And they recommend using vasopressin in babies with diaphragmatic hernia. The thing with vasopressin is that although it's really effective in improving blood pressure, it tends to have a higher risk of oliguria and hyponatremia. So you should carefully monitor urine output and serum sodiums while using vasopressin. So to conclude, it's really important to maintain high fetal hemoglobin through placental transfusion and minimize iatrogenic blood loss so that you can maintain high levels of hemoglobin while managing these patients. Gentle ventilation is really key. Try to maintain low RV stress by using a combination of milrinone, IV PGE1, and pulmonary vasodilators such as inhaled nitric oxide while you are using gentle ventilation with relatively low PEEP to avoid volute trauma in these babies. I thank you for your attention, and here is my cell number, my Twitter feed, and my email. I would love any input from you regarding this topic. Thank you. I'm happy to take any questions. You can either put them in the chat box or you can unmute yourself and ask a question, and I'm happy to answer those. We still have 5 minutes.
Satyan, can you hear me?
Yes, I can.
Hi, this is Pam Bali. I'm one of the neonatologists at UC Davis working with Satyan. I just had a question regarding that recent publications in Annals of Surgery regarding the CO2 and using it as a predictor of ECMO. I was just hoping you can talk a little bit more in detail, looking at whether they categorized the severity of the CDH? Because I can't fail to wonder whether the babies that had lower CO2s just had less severe lung disease, whether the liver was down or whether the expected to observed ratios were lower, and if they took that into account when they analyzed the data.
Yeah, that's a great question, Payam. They actually did several subclassifications within this paper. I'll email you this paper when we get off this call. They had several subcategories where they matched the lung disease, where they also matched regarding the presence or absence of cardiac disease, etc. But this paper was more to evaluate the usefulness of ECLS in ECMO in CDH. And what they were pointing out is that if you can manage PCO2 fairly low, even prior to ECMO, there might not be a great benefit of using ECMO was the essential point that they wanted to drive home. But if you can get the PCO2 down in a certain range, typically if the lowest PCO2 is between 61 and say 90 or something like that, then they thought that ECLS was much more beneficial. But then obviously if the CO2 goes too high, not much benefit. So they were stressing more. And as you rightly pointed out, this is data from the registry. So this is all comers that the data was dumped in. So it was not a prospective study. And so that's something for you to, that's obviously a caveat. Hopefully, we will have some similar data from the two prospective trials. One is the Millennium trial and the Congenital trial. And if we can prospectively evaluate this, that will be much better to evaluate the use of this. There are several other things that we can look at. One of them is the PaO2 minus PaCO2. So if that number is less than 0, in other words, if your PaCO2 continues to be higher than your PaO2, that's not a good sign either. So these are all signs suggesting hypoplasia, and you're absolutely right. Randomizing these patients or classifying these patients used on observed expected LHR or fetal lung volume would be much more accurate, but I don't think we have that information.
All right, thank you.
Thank you. And let me look at the question.
Hi.
Hi.
Can you hear me?
Yes, I can.
Hi, my name's Layman Black. I'm a retired PICU doctor from Sutter.
Hi, for you.
And my question really is about oxygen toxicity. Years ago, back in the 70s, with adult volunteers, they were given various levels of oxygen, and they attempted to measure what amount was toxic. And I know you mentioned feeling relatively comfortable at the 35% or 0.35 FiO2 and maybe going up to 50%. Isn't there evidence that 50% is toxic to lungs? And I would think maybe more so to the neonatal lung?
That's a really good question. Interestingly, when you look at animal studies, neonatal animal models are much more resistant to hyperoxia from a lethality perspective than adult models. And for that reason, most people who study, say, for example, if you're evaluating rat pups or mouse pups, you have to take the mom out of hyperoxia fairly often so the mom doesn't die. So it's kind of paradoxical. It doesn't make much sense, but that's what we see. But your point is very well taken. The issue, however, is that if you are maintaining, the problem is that we don't know for sure if every alveolus in the lung of a baby with CDH is seeing 50% or not, because there is heterogeneous distribution of FiO2 in some cases. For that reason, if you can't maintain if you can maintain a PaO2 of 50 to 80, by all means stay at the lowest FiO2 that's possible. But if you can't maintain a PaO2 of 50 to 80, say your PaO2 is 40, in those patients, it's good to slightly increase your FiO2 up to around 50% so that you can achieve better PaO2. There are no trials in term babies to this date, including PPHN or diaphragmatic hernia, where they have evaluated different levels of FiO2 and PaO2 in human clinical trials to evaluate this. So the bottom line is that we don't know the proper answer to your question, but based on animal models, it appears as though maintaining O2 sats in the low 90s or PaO2 in the 50 to 80 range is probably optimal. There is a question on, can you share some insight on ECMO strategies for patients with diaphragmatic hernia from Dr. Neonatal?
Well, I'm muted now,
Okay.
and this is over now, pretty much.
So Dr. Mittal, I did not specifically go into ECMO strategies, but as far as possible, try to do VV ECMO if the main limitation is pulmonary hyperplasia. But the placement of the Avalon cannula sometimes might be tricky in babies with diaphragmatic hernia because of altered anatomy. And in those cases, sometimes they land up on VA ECMO. But if you can do VV ECMO, that's probably better. I don't do a lot of ECMO myself, or PQ does it, so I may not be able to share much more details with that. I don't have a lot of expertise in that area. Gaurang is asking us to whether most MFM physicians do LHR for diaphragmatic hernia patients routinely. Yes, they do. Either they do LHR or they typically get you a total fetal lung volume, TFLV measurement. And if you're not getting those, it's worthwhile asking them to get it. So most patients either give you a crude LHR or a observed to expected LHR ratio and take it from there. So there is, you should be able to get that number from most MFM people. We are out of time, so I'm going to stop, but I encourage all of you to consider sending me recommendations for speakers or topics for the future. Anybody in this country, I'm happy to try to invite them. If they're really well-known speakers, it might be difficult for me to get them to present, but as long as we give them a date far ahead in advance, we should be able to have them come and talk. One benefit of these Zoom calls is that people don't have to travel, and for that reason, we might have a better chance of having somebody give us a talk on any topic that you would like. Last question from Thi, is right radial or right limb arc line standard of care? No, it's not standard of care because most of us still use umbilical arterial lines. But I encourage you to read the paper by Jason Geen from Children's at Denver, where they show that the use of preductal PaO2 results in much less oxygen toxicity and slightly better outcomes. So that's an interesting paper to read. Thank you again for attending, and feel free to email me if you have other suggestions or other comments. Thank you. Have a great day.